Welcome back to Crush Medical. We've got a easy slash medium pass level question for rheumatology. Make sure to like and subscribe, help this channel grow, and we're going to continue putting out more free content and questions. Okay, so let's jump right into it. A 67-year-old woman with long-standing hypertension reports several months of bilateral hand pain, worse with use and at night. She has no fever, rash, prolonged morning stiffness, or other joint involvement. On exam, the DIP and a few PIP joints are tender and mildly enlarged bilaterally with no warmth or erythema. What is the most appropriate initial treatment? Okay, so very commonly tested, frequently tested topic right here, and you can't miss this. Okay, so let's break it down one by one. We've got a 67-year-old woman, so of course she's not exactly young slash middle aged. We're talking about seniors, right? And essentially she has long-standing hypertension, okay, but she's been describing bilateral hand pains that are worse with use and at night, right? So that typically describes a very textbook presentation for osteoarthritis, right? Which is the wear and tear of bones and joints. The more you use them, the more heavy lifting or joint involvement you do, the more wear and tear you're going to experience, and that is how the symptoms progress, right? Um, they also mentioned that she has no fever, rash, or prolonged morning stiffness, which is really reassuring, but also it kind of clears out some of the other differentials, okay? And of course, they mentioned the joints involved, the DIPs and the PIPs, which are the most commonly affected in osteoarthritis. And the last point they do share is that there's no sense of warmth or erythema, which is, again, very reassuring, okay? So let's jump right into the options. Let's just start from option A. So methotrexate, right? Methotrexate is one of the examiner's favorite drugs to love asking questions about. And methotrexate would in fact be the first line for rheumatoid arthritis, right? So rheumatoid has the DMARDs and the non-DMARD. So methotrexate would technically be the DMARD for rheumatoid arthritis, as well as a lot of inflammatory conditions, right? But in this case, it's just the wrong answer here because there's no benefit from methotrexate for rheumatoid arthritis, or sorry, for forgive me, for osteoarthritis, okay? So in this case, it is the incorrect option, okay? Moving on to option B, so oral prednisone, which is another, you're essentially giving them steroids for if you're suspecting any autoimmune or any inflammatory joint conditions. So in this case, it would be incorrect as well, right? So systemic steroids are not standard initial therapy for osteoarthritis, and essentially they're saying that you do not want to give like systemic steroids for somebody who has osteoarthritis, right? Perhaps if they had ankylosing spondylitis or they had rheumatoid arthritis, then using steroids does have some benefits in essentially shutting down the immune system to stop all the damage that is taking place. But in this case, for osteoarthritis, which is wear and tear of the joints, um, incorrect here, okay? Our next option is jumping into topical or oral NSAID therapy. So this would be the correct answer here, right? So this is hand osteoarthritis is what this patient is dealing with. DIP, PIP joints are involved, and there's no underlying inflammatory features, right? There's no warmth, there's no erythema. So these are things to be aware of, right? And this is how we can quickly identify that this is in fact osteoarthritis and not some other septic arthritis or other joint pathologies that we can commonly see, okay? So now that we've established that, again, first-line therapy, NSAIDs with topical is preferred to limit systemic effects, okay? Um, so again, we mentioned this is a very textbook pattern for osteoarthritis patients. You know, pain with use gets better with rest. No inflammatory features, again, that's really reassuring, and in this context, topical is preferred. In this patient, she does have chronic hypertension, right? So considering using acetaminophen, which is actually one of the first line drug you should be using for osteoarthritis pain, that is instead of saying topical or oral NSAID therapy, they said acetaminophen, that would be the best option. Okay, so keep that in mind, okay? And moving forward, let's just see the two other last options here. The first drug is allopurinol. Allopurinol it is definitely a high yield drug for board examination purposes. A few key considerations would be if you want to prevent gout, that's one of the medications we're going to be using. Allopurinol does an effective job at preventing gout, but also something called tumor lysis syndrome, right? So somebody who's undergoing chemotherapy or has a high tumor load. Allopurinol does have benefit for that, and it essentially saves your kidneys from further damage and destruction in those clinical settings. Okay, so um, in this case, though, for this clinical patient who has osteoarthritis, allopurinol is the wrong answer. Okay. And that leaves us with our last option, hydroxychloroquine. This is a really interesting drug. Again, when you talk about rheumatoid arthritis and their arms of management, and you mentioned DMARDs, so hydroxychloroquine will also fall under possibly treatment for rheumatoid arthritis as well as lupus, right? So a lot more systemic inflammatory autoimmune conditions. Hydroxychloroquine is definitely on that list, but for osteoarthritis, it's just not a drug that we would even consider using. Okay, so very high yield question. Do not miss this. This is tested very frequently, and you just have to know the in and outs of osteoarthritis management as well as the distractors. So if you found this video helpful, again, make sure to like and subscribe. We'll see you in the next video.